I would like to welcome everyone today to today's national webinar hosted by the AATC National Coordinating Resource Center in collaboration with Hofstra University. Today's webinar, the role of institutions of higher education in ending the HIV epidemic. I would like to now introduce today's speakers. Dr. Anthony Santella, Associate Professor of Public Health at Hofstra University. Dr. Lisa Hightower-Weidman, Professor of Medicine and Health Behavior at the Institute for Global Health and Infectious Diseases at University of North Carolina at Chapel Hill, and also the Director of Behavior and Technology Lab at UNC. Ariel Watrous, Nurse Practitioner and Sexual Health Specialist at Tufts University Health Services. At this time, I would like to now pass it over to Dr. Anthony Santella.
Thanks, Liz. First, before we get moving with the presentation objectives, let me just thank the AATC National Coordinating Resource Center, in particular Liz Lasso and John Nelson, for their help in organizing today's webinar and for bringing Lisa and Ariel on as speakers. We're going to cover a lot, so I'm going to keep going. You can see here our presentation objectives to describe briefly the epidemiology of HIV and AIDS among young people, explain why the college campus is a unique setting to deliver HIV testing and make college students aware of their serostatus, explain why college health centers are uniquely positioned to offer pre-exposure prophylaxis, or PrEP, as a routine part of their services, and discuss how college students can engage their campus communities in ending the epidemic strategies. So let's go on with section 1, which is about the epidemiology. Before I do so, I just want to acknowledge, first of all, I hope everyone is in a good place, healthy, and I want to acknowledge really what's going on in the world as a public health scientist and practitioner. We need to acknowledge, the multiple and dueling public health crises. If you think about climate change, COVID-19, anti-Black racism, and other forms of hate-driven violence, clearly there's a lot going on in the world. Like I said, I hope everyone is in a good place today. When we think about the HIV and STD epidemics, these are syndemics. They interact synergistically with one another. Here you see some national data as it relates to the HIV continuum of care. And we know the goal, whether we're talking about college students or the general adult population, is to ensure that all people with HIV are diagnosed, receive and linked to HIV care and treatment, retained in that care and treatment, and achieve the ultimate clinical milestone, which is viral suppression. We also know that, recently the CDC indicated that we're at all-time high rates when it comes to the STDs of public health significance, in particular chlamydia, gonorrhea, and syphilis. And so what we've done in the past, historically, particularly with young people and college students, clearly is not enough. So we need to re-engage and re-envision how we provide STD and HIV services along the prevention, care, and treatment continuums to engage this population. We know that of the over almost 38,000 new HIV diagnoses in the U.S. In 2018, about 1 in 5, or 21%, were among youth. Moreover, most new HIV diagnoses among youth were among young, gay, bisexual, and other men who have sex with men, as you can see from the bar chart along the left. When we look at young women, we see that about 85% of new diagnoses are due to heterosexual contact. HIV diagnoses have declined 10% among youth from the period of 2010 to 2017, although you can see some variations here. We know that HIV diagnoses also declined for the groups most impacted by HIV, again, young, Black, African-American, gay, bisexual, and other men who have sex with men. So we are seeing declines when it comes to new diagnoses. As far as that clinical milestone of reaching viral suppression, we're not doing good enough. We know a few things. One is that out of the over 1.1 million people with HIV in the U.S., about 51,000 were young people, and about 4 in 7 knew they had the virus. So when we think about that first step in the HIV continuum of care being diagnoses, 4 in 7. Again, considering that HIV testing, we have good diagnostics available, this should be better. When we think about, again, that viral suppression milestone, you can see that for every 100 youth with HIV, only 43 received some HIV care, 31 retained in care, and only 30 out of 100, or 30%, were virally suppressed. And clearly there are a lot of challenges, and this list provided by the Centers for Disease Control and Prevention is not meant to be exhaustive. We know that first, there are low rates of HIV testing, which is why you're going to hear in a few moments about HIV testing in college students. The American College Health Association, in a recent survey of over 26,000 college students, found that only 27% had ever received an HIV test. So I'm not talking about in the past 12 months, I'm talking about ever received an HIV test. We also have low rates of PrEP use, which is why you'll hear about PrEP in college students from our second speaker, or our third speaker, excuse me. These rates have been historically low. We also know that addressing the social determinants of health are important, not just for adults, but the entire continuum of our lifespan, including youth. And then finally, high rates of STDs, particularly those STDs that are largely asymptomatic and are often present in the 20-somethings, like chlamydia and gonorrhea. But we've made good progress, so I don't want to make things seem all doom and gloom. Thankfully, we now know that U equals U, undetectable equals untransmittable, and people who have achieved viral suppression cannot sexually pass on the HIV virus to others. But we have to think about what it means to be a young person with HIV in the college setting, whether they're living in a dormitory or not. Thinking about the stigma, discrimination, access to care and treatment, perhaps when they're away from home for the first time, and other forms of psychosocial support from peers and from the adults in their lives. We also know that there's been several initiatives towards ending the epidemic. The most recent federal initiative was announced by President Trump in his 2019 State of the Union address, which was a new plan for the 2020 to 2030 period. And the motive behind this is because we know with solid epidemiological and surveillance data that without some kind of major national strategic intervention, that we could expect another 400,000 Americans to be newly diagnosed with HIV over a 10-year period. And the federal government spends over $20 billion in annual direct healthcare expenditures for HIV prevention, care, and treatment. And lastly, we know we are at risk for an HIV resurgence due to things like diagnostic complacency among clinicians and emerging epidemics like we are seeing with the opioid epidemic. And so this federal initiative seeks to have a 75% reduction in new HIV infections in the 5-year period from 2020 to 25, and in the period from 2020 to 2030 have a 90% reduction by diagnosing people early on as possible, treating everyone with HIV with effective antiretroviral therapy, preventing new transmissions with the use of PrEP and syringe exchange programs, and responding quickly and efficiently to outbreaks. And this is done by focusing on the 48 highest burden counties. I know it's a little difficult to see on the slide, but you can see those represented by the dots, as well as Washington, D.C., San Juan, Puerto Rico, and 7 states that have substantial HIV burden. So by focusing on strategic areas, we can get the most bang for our buck. And while we've done a lot, think about the early days of the epidemic where you saw headlines, for example, what you see on the left hand of the slide, rare cancer seen in 41 homosexuals. We've made great strides in the past 4 decades. Dr. Anthony Fauci, who now is a household name because of his role in the National COVID Task Force, has really been a career infectious disease clinician and public health scientist. He said it best when he said, the challenge before us is to deploy for everyone who needs them the innovative strategies for HIV prevention and treatment that have resulted from the unprecedented basic scientific and clinical advances made over the past 4 decades. So again, we need to do more and better. On that note, I will pass it on to our next speaker.
Great, thanks so much. I'm Lisa Heitzer-Weidman. I'm from UNC, and I'm excited to talk about HIV testing in college students. And, I think, to kind of think about why we need to talk about testing in college, we have to go back a little bit and think about what's not being done in high school or middle school. And, I think we really, are, unfortunate that there is just, not kind of the comprehensive, holistic approach to sex or education throughout the entire U.S. While there are some regions or locations that actually do teach about HIV and STIs and pregnancy prevention, it's not widespread. And so again, you see that in this slide, this comes from the CDC, that there are many sort of schools that are not actually teaching what youth need to know. And this doesn't even get into the fact that there are still places where folks are not allowed to talk about anything but heterosexual sex, abstinence, and in some places where if they actually do talk about same-sex relationships or sex in general, it has to have a negative tone. So certainly a lot of work to do kind of even before folks get to college. And so, why do we need to also think about prevention on campus? Well, again, college students and young people in this age group in general engage in sex, have high rates of sexual activity, sex with numerous partners, inconsistent condom use, and sex under the influence of drugs or alcohol. So certainly all things that put folks at risk for acquisition of HIV or other STIs. In addition, this college is a period where for many young people, they may now be living on their own for the very first time. They're certainly more receptive to messages and it's easier to keep a healthy kind of a lifestyle if you adopt it earlier. Again, I don't know about the old dog, new tricks, but it definitely, it's better to start on the right foot rather than having to kind of go back. And again, the idea that this is a place where folks are open to new ideas, and this may be a good place to kind of start behaviors such as testing and prevention that can last a lifetime. So here's some of my early work. Sort of is, again, brings me back to kind of work that I did when I first started, some many years ago now, but where, we had seen what we called kind of an epidemic of HIV in the southeastern U.S. And we, were one of the kind of early groups to report an increase in HIV infection among young Black men who were having sex with other men on college campuses. And this was kind of an early network. I still love it, but it's certainly not the type of network studies that true network scientists put forth. But it was, it was me in a PowerPoint. And what we found was that, again, what is not surprising now are that, these infections are linked because, people have networks that span schools, that span states. And, it's really important to understand these networks if we are going to increase our ability to stop transmission. And so this led to, I think, still my favorite study that we've ever done, which is called STYLE, Strength Through Youth, Livin, Empowered. Myself and Justin Smith, who's, I got a text, so he's on this call, but who's gone on to bigger and better things since he left working with me. But he was my project coordinator, and we created this this program that we sort of was very homegrown. For a while it was just the two of us, and then obviously we had some community partners that came on board and HBCUs in our area. But the idea was first and foremost, we needed to do social media to make folks aware that young, gay, bisexual, and other men who have sex with men were living in our area, and if they were, and they were on our college campuses, we wanted to get them into care. So we created a project such that we did a college tour. We went to any place that I think for a while asked us to go. We went. I think I remember us showing up at one health fair that was, I think it was the majority, was 10 60-year-old African American women, but Justin and I went and had hot dogs. But the idea was that we wanted to promote social awareness. We wanted to make sure that we addressed stigma, and we wanted to do more testing on college campuses. And so this is an installation from one of the schools where they actually did this amazing art installation where they put out shoes for all the different cases of HIV in the area, and the shoes kind of wound around and around and around. It was pretty impressive. So in our work, we tested over 3,000 North Carolina college students. We found 10 new positive cases that were linked to care. And we did schools, really kind of all the different schools. Again, we had a lot of youth buy-in. Initially, we had less buy-in from administrations, but because there was concern about stigma, they didn't want to be known as an AIDS school, which, again, just the idea of that certainly, is stigmatizing. But we sort of tried to reverse psychologize them and kind of said, well, every other school has agreed to let us come, so if you don't, it would look kind of suspicious. And, we started that when I don't think anyone had actually agreed to let us come, but it worked. And so a lot of the schools let us on campus. And again, we weren't expecting necessarily to find a ton of new positives, but we wanted to make sure that folks on the campus knew who we were, knew that that we were a place that they could get information and that they could get testing really at any time, and that in addition, if they were living with HIV, they could connect with us to get into care. Our testing events was always free, rapid. This was, again, kind of the beginning of oral testing, so it was new at the time. We also did group and individual pre-test counseling. So again, the idea that you could do kind of group-based individual counseling. We used a lot of the students wanted to be involved. They were really excited, and so we found that graduate students were a good kind of group to do the counseling because they were sort of peers, but near peers. So they weren't necessarily in the same social circles, but they weren't me, who was a little bit old, and so there was, again, this kind of ability for them to kind of give information that was well received. And again, there was a physician that was usually me on site for referral or very close by. And again, we did a lot of co-sponsorship with campus organizations. So, that was kind of the work we've done. What other data is there more recent? Because that's, been a little bit. So if you look at the National College Health Assessment, they do this pretty frequently. And this was the fall one, as you can see from the beautiful trees. And, they do kind of it on these sort of reference groups, and it depends on each sampling frame, how many folks they're testing. But again, what they found was that, overall, if you look at every single, assessment each fall and spring, the findings are pretty similar and pretty dismal in that most college students have not tested for HIV in the past 12 months. Most are having sex, and again, I think, folks are having vaginal sex and anal sex, and again, I think, as a reminder, women also engage in anal sex, so it's a really important when we talk about kind of screening for STIs. I think, this part was interesting to me was that of those reporting having vaginal intercourse in the past 12 months, this was both men and women, that 15 and 17% of those asked reported that they'd used emergency contraception. So to me, this is sort of like the PEP of, post-exposure prophylaxis for contraception. And again, this would imply that, there is not only risk for contraception, but certainly probably a similar risk for HIV acquisition. This is an HIV risk assessment done by researchers in HBCUs in the South. And again, I think, the idea is that, the majority, or, not an insignificant majority, a minority had never tested, so 40% or so, but most were sexually active. About 9% of the men reported same-sex partners. And again, I just think that, high rates of inconsistent condom use. And again, this study was done, recently, and it was striking to me that 86% of folks had not heard of PrEP. I think the other thing that we have to just recognize is that, stigma is persists. And, while we make some small steps forward, we also, with, things like U equals U, we also have to recognize that, stigma, misinformation, mistrust, all of that still persists. And again, this is a recent study, in the past, 5 years of young adults, 18 to 30, and folks they were comfortable having someone with HIV as a friend or work colleague, which again always, strikes me as I'm comfortable. What does that mean? They were uncomfortable having a roommate or having their food prepared by someone with HIV. So again, there's no risk of transmission by a somebody preparing food. Again, 3/4 were very uncomfortable with a sex partner with HIV. Again, well, as presented by Anthony, we know that folks that have HIV and are undetectable are untransmittable. So probably safer to have sex with somebody who's virally suppressed than somebody who doesn't know their status. Again, more than a half had never tested, and nearly 2/3 say they've never talked to a provider about HIV. So I think we have a lot of work to do. Again, just a little bit more around stigma, because I think it's a point that we have to continue to address, is that in this study in university students in the Southeast, testing was associated with higher knowledge, and higher knowledge was associated with lower stigma. So, while, knowledge itself does not change behaviors, it is a prerequisite for any behaviors to be changed. And, folks that are ignorant are not going to, are going to be the ones that are going to promote, continue to promote kind of stigma, and we have to ensure that we have facts, information, and at least as a prerequisite to trying to address some of this persistent stigma that exists. And why does this matter? Again, colleges are micro-communities composed of individuals from all walks of life. As I found kind of early on in the networks we did, again, colleges are not, regardless of where they are and whether they're public or private, et cetera, they exist within communities. I think we've seen this to a huge degree with COVID, right? These college campuses that are having outbreaks of, that had kind of brought folks back in the fall and then had to send folks home. There's no walls, even if there are, kind of, looks like there are from kind of how the campus looks. So it's really important that we address HIV on campus. It reduces community burden. It improves our public health. Individually, it's important to reduce comorbidities and to improve mental health. But at the barest level, it's cheaper to address it now and treat it than to wait. So here are some best practices. Again, this is from the WHO, and just is a definition of sexual health. I think my reminder is that sexual health is not just sex. It's about all of the physical, mental, social well-being that happen as a result of sexuality. And so if you don't kind of provide this information in a welcoming and inclusive environment, there's no reason to do it. And again, this is my last slide, is just to remember that there are also other places for folks to test, not necessarily just on campus. I mean, I can't imagine, I'm working a little bit with our student health at UNC, but, student health, has a lot of work and are doing an enormous amount of work related to COVID that is really, over and above and exceptional. And so, other places, if they can't provide services, particularly during this time, looking for other places that they can help get students tested, home-based options. I do a lot of work. My research work is usually around technology-delivered interventions, which include access to home HIV testing, PrEP, et cetera, but again, if, particularly now when we're, all overwhelmed with kind of the COVID that is taken over, is ensuring that we don't forget about HIV and we don't forget about STIs, because it is, we know that folks are still having sex. We also know that folks, particularly young people, are increasing their alcohol and drug use in this time. Their mental health is decreasing, and we have to keep this in the forefront of our minds. So I think I've kind of summed up, but I think, this is a crucial time and a place to test young adults. We need to do it in a way that is responsive to their needs and to promote healthy, ongoing, intimate relationships with their partners moving forward. Thank you.
So Ariel here now, building off of Lisa and Anthony's slides, we need to address more specifically how college health centers are really positioned in a beautiful way to help PrEP be a part of their routine services. So I'm not going to get into this too in depth because we've already heard a lot about this. We know that the populations that are in college are at risk. They are the ones that need more information and need more access. They're also combining all of this with a new time in their lives of new independence. And for most of them, it's this context of the first time that they're engaging in having to deal with their own health care and navigating all of those things for the first time. And in conjunction with that, more often than not, again, we have folks who really don't have that sort of baseline body knowledge and health knowledge about what they need to know about their own bodies. More often than not, I meet young people who are coming in with a sexual health crisis or concern, and they don't even understand the basic components. So back to what Lisa was saying, we know that they're coming in with these gaps of knowledge from high school that we would love to have filled sooner. So the themes of health needs in college certainly are not just around sexual health. They're around multiple components of health. And as has already been addressed, we are in this incredibly unique time where people are experiencing pandemic context and life is still moving forward. So they're coming in these heightened times of stress and they are feeling overwhelmed even more, but their lives still continue. They still have these new places of sexual awareness. They're still having access changes. They're still developing this new autonomy. Even within the context of COVID, even in the context of these really strange fall semesters, the hookup culture exists. There are perceptions of what the other people, in quotes, are doing around their sexual health. And they still have these gaps of knowledge that need to be filled. And one interesting thing that I'm seeing is that people are actually having layers of shame added to their sexual health shame because they're feeling that they have to protect their health and people around them, their health as well around COVID, and then they still are engaging sexually and they may not feel completely comfortable sharing all of this with the provider, which I think is very interesting. So what are the components of benefit around offering this? Well, at its most basic, it is an opportunity for us to help our students become more empowered and develop more sexual health autonomy. And the good news, and this is especially applicable to right now, is that we have a lot of ways that we can implement this. Back when we first started providing PrEP, we felt really strongly that people had to come in face-to-face every 3 months for their visits and their testing and everything. And what we've learned since March of 2020 within the context of this pandemic, that a lot of this can be evolved to online services, FaceTime, Skype, Zoom, phone calls, and then sending somebody a lab requisition so they can continue this medication so they're not running the risk of losing the medication or even starting somebody for the first time. And a lot of other places, a lot of colleges are already providing HIV prevention services. So if we have commons on campus and we are able to talk about all of these things already, then this is an opportunity to just add to that space that we've already created, which is great. This has been addressed before by both Anthony and Lisa, and I want to address it again, that if we are talking to our students about STI prevention, we really need to include PrEP as a part of that. And it doesn't have to be a slide set, it doesn't have to be a full appointment, but it needs to be mentioned in the context to mainstream, to normalize the access to PrEP. And so every STI appointment really, truly is an opportunity to talk about PrEP and invite students to kind of know more about it. The context of a positive STI diagnosis makes it even more important to make sure that we can talk about PrEP, because we do know that there is increased risk for HIV transmission with certain STIs. If we think about the mucosal changes with certain STIs like gonorrhea or chlamydia, or even the open ulcers of herpes, we do know that those can make the transmission even more acute for HIV. And so we really, really want to be mindful of that. There's countless research showing us the number of missed opportunities that are presented. And I appreciate it. Anthony said before, the diagnostic complacency around HIV testing, that also pertains to being able to talk about this sort of generally and to streamline it for our students. This is a quote from the ACHA, American College Health Association PrEP guidelines. I had the honor to be on this task force to help write the guidelines for the national guidelines for PrEP on college campuses. American College Health Association believes the ongoing HIV epidemic is an urgent health priority and that college health centers can make a significant impact in the health of young adults by offering PrEP as a standard healthcare service. College health services are uniquely positioned to implement comprehensive evidence-based prevention strategies that can help end the HIV epidemic among young adults. So, whenever we talk about folks starting this out for the first time in their clinical spaces, we do want to acknowledge that there are a lot of components that can be barriers for it. The main one is stigma. We've talked about stigma before. We've talked about how this can impact it. Lisa mentioned that the stigma persists. A big component of why the stigma still persists is because we, the providers in these contexts, need to help change it. We have the ability to address in ourselves the implicit bias that we might be holding onto in ourselves that make it feel weird for us to talk about this. And if you were able to work in a clinic where there is birth control offered, then this can be something else that can be offered as well. But it definitely takes a moment to sort of think about what it is that's stopping us from feeling comfortable about it and to be able to adjust our expectations around our clinical care and moving forward. Another big concern I hear about is what about access over the summer? The good news is that a lot of insurance companies are starting to step up to this and are able to offer coverage for 3 to 4 months. There are also more access points nationally than there were about 5 to 6 years ago around getting filler prescriptions or even starting it. And preplocator.org is a good option as well. And then, of course, as I mentioned before, we have online and virtual options for appointments. The cost does vary, and I can't dismiss that this is still in some cases definitely a barrier for folks. And there are some states that do have financial support programs available for students. Another big concern that I hear about from people is adherence and being concerned, can a student manage this? The good news is that they can, and if they are feeling that they can't, what are the barriers? It's an opportunity to help the student develop independence around the context of their lives. Do they need to be able to carry the pills with them? Do they need a reminder on their phone? What are the components that we can help change that will help their adherence be stronger? Another concern, too, is the worry around if there's going to be risk compensation, if someone's going to decide that they can do other things that are more sexually, in quotes, risky if they're on PrEP. This, again, is an opportunity for us as the providers and health educators and, student peer leaders and educators to really address what people are understanding in their own sexual health and how we can help them be able to feel empowered in their sexual health and to also understand what the other risks are if they're using PrEP. Because PrEP isn't the be-all for all STIs, right? We know that we have to be able to implement it and also still talk about the other STIs that we want to help reduce the risk of transmission for. So we need to be able to support people around this decision-making and also understand that it's not as if you're giving them an access card to do whatever they want. And that's an education space that we as the providers and health educators need to appreciate. A lot of places are interested in starting PrEP and may not feel empowered to do it. The guidelines that were written for the ACHA are offering samples of protocols that are available online, and they're available at acha.org. And I'm going to pass it back to Anthony.
Great. Thanks, Ariel and Lisa, for your insight on HIV testing and PrEP. We're now going to move into the fourth and last section of the webinar before we go into the questions and talk about a specific project that I've led on Long Island to engage college students in ending the epidemic efforts. So by way of background, Long Island is the New York City suburbs, where we consist of 2 counties west of New York City, and have about 3 million people and 12 colleges. So clearly we know that college students are an untapped population when it comes to ending the epidemic efforts. And we've talked about already all the good reasons why we should be incorporating them as a major stakeholder in EHE-related work. And to date, really, there hasn't been any strategic or intentional incorporation of college students and their stakeholders into ending the epidemic efforts. By way of background, in New York, let me tell you a little bit about how ending the epidemic has worked in New York. So New York State became the first jurisdiction to launch a statewide ending the epidemic blueprint in 2015 that has 3 pillars: identifying and linking undiagnosed persons to care, retaining them in care, and facilitating access to PrEP. So what happened was in 2013, a group of community leaders, advocates, community-based organizations, researchers, and more really demanded more, that we do more to end the epidemic. They spoke with our governor, Governor Cuomo, and colleagues from the State Health Department, which then engaged over 300 stakeholders gathering input. They developed a task force. Fast forward, a lot of work happened. In 2014, a blueprint was produced, and in 2015, it was released by Governor Cuomo. And so in addition to having the blueprint, which we know is important, we also have funding, which I know it's hard to see, but you have the citation on the bottom of the slide, dedicated towards ending the epidemic. And so you can see you don't not only need a strategic plan and vision, but you need the financial and human and information resources to accompany it. At the local level, so that statewide blueprint is then operationalized and implemented at the local level. So we have kind of ending AIDS Long Island, and both Nassau County and Suffolk County, which make up Long Island, have their respective ending the epidemic committees, which strive to implement the plans at the local level. We meet monthly. We engage in activities to facilitate activities around those 3 pillars on testing, retaining people in care, and facilitating access to PrEP. But historically, we've done a pretty poor job in involving young people, not just college students, but young people in general in our work. And so the 2 regional committees, Nassau and Suffolk County Regional Ending Epidemic Committees, along with a similar project called the Long Island HIV Community Mobilization Project, we developed this Campus Advisory Committee. We received funding from the New York State Department of Health AIDS Institute. They have a special projects grant where you can request monies for up to a year to pilot new initiatives toward ending the epidemic. And we proposed this Campus Advisory Committee, which would do the things that you see on the bottom half of the slide: promote meetings, events, campaigns, engage young adults in our efforts by co-sponsoring events, having them review promotional materials, having them assist members, organizational members of the 2 committees with outreach and education at various community events, including things like Pride events and national HIV testing events, et cetera, and to promote service learning opportunities on their respective campuses. We used part of the funding to pay them. So the committee members received a $250 gift card for their participation across the entire academic year. So we invited all 12 higher education institutions on Long Island to participate by contacting their respective leadership through different listservs and direct contact through, for example, Vice President of Student Affairs and Health Centers, things like that. They were given a link to the online application and asked to distribute it widely, not just to students interested in the health professions and medicine, nursing, et cetera, but the entire student body through student clubs, through student affairs listservs, social media, et cetera. That online application asked for demographic characteristics, why they're interested in joining this board or committee, what other organizations do they belong to, what kind of time commitment, could they give during the academic year, and ideas they had for doing this work. For this first year, the pilot year, we limited the applications to sophomores and juniors. We wanted, it's hard for freshmen already to get adjusted, and so adding something like this we thought wasn't the best idea, and we know a lot of seniors suffer from senioritis, and so we wanted to ensure, people were really ready to roll up their sleeves and commit to the work, and that was just for the pilot year. We then reviewed the applications, the leadership of the different committees, and myself as the project lead. Our initial plan and what we proposed was to have 2 students from each of the 12 institutions, so 24 students. That didn't happen. 2 of the 12 institutions did not submit any applications, and so we had to redistribute our slots in essence. And then once we announced the 24, we asked each of those schools, we obviously told them who from their institution had been accepted and asked them to create some buzz around it. We gave them some language and some information that they could post around. Here you can see our group. This picture was from a year ago when we met for the first time in October of last year at Hofstra University. You can see on the table the list of students in the universities they come from. They ranged from associate degrees to bachelor's to master's to medical students. So we had the full gamut of student involvement. And you can see there's, 1 student from some places, 4 from another. While we started with 24 students, we ended up with 18, 6 left for good reasons. 2 of them withdrew from school temporarily for personal reasons. 1 person went to the Army. 1 person transferred schools out of state. Things happen. So we went from 24 to 18. We had an orientation a year ago. We met 4 times over the academic year. Each of those meetings, whether they were virtual or in person, had a training component. And then they were given requirements. In order to earn, we split up the 250 into 125 and 125 for the fall, 125 for the spring. They had requirements and deliverables they had to attain in order to receive that gift card. And so you can see them listed here. They were pretty low-key, attending meetings, helping Ending the Epidemic Committee organizational members with their community outreach, helping facilitate work on their campus. And they had a buy-in into the deliverables. We came to them with drafts that we were pretty comfortable with, but we tweaked them a little bit based on their feedback. This is just an example of some slides from the campus presentation we asked to give them in the spring. The leadership of the Campus Advisory Committee developed what would probably be a 20 to 30-minute interactive presentation with Q&A about HIV 101 and the work we were doing to get some buy-in on their campus. Our desired outcomes were to improve knowledge, improve skills, and improve campus awareness all around ending the epidemic in our state. And of course, there were some challenges. Working with college students, again, from the associate's degree to the medical student, was challenging to get them all on the same page and meeting together and then stay focused over the course of an entire academic year. And then, of course, COVID happened, which meant everything became virtual. Most of the schools then shut down during the middle of the spring semester or moved to online, and that meant several of the spring deliverables could not happen. But we were confident that this pilot was successful. We now are talking with the state to expand it to be statewide and think about other opportunities to engage college students and sustain this work well beyond just our pilot year. And on that note, we have about 10 minutes for questions. We covered a lot, but we certainly want to make sure we were respectful of your time and allowed people to ask questions. So you can post something in the chat box, whatever's most comfortable for you, and 1 or more of the speakers would be happy to address that. So thank you again for attending today.
Thank you to our speakers. So as Dr. Santella mentioned, we would like to open it up to questions from participants. As a reminder, to unmute yourself, please press *6. But to get us started, I just want to point the discussion point that was mentioned in the chat box from Lisa Curry regarding college students often are uncomfortable having any sexuality-related testing or medication charges go to their parents' insurance. This is an area ripe for education and how to have those conversations and increase their autonomy. So I don't know if any of our speakers want to add anything to this.
Yeah, Ariel here. I'm happy to address this. This is a great point, and that a lot of students are still on their family's plans, and there are parameters for each plan and also for different states as to how much information is shared with the prescriber, right? The insurer, the main person. I agree with this comment that it is an opportunity for education. I do think that a lot of the conversations that I have with my students around sexual health care and also PrEP do involve a discussion about the insurance, and it's either copays or access to other services that will not require the insurance use. There are some states that have the ability to have all information around certain sexual health topics including sexual health, go directly to the person who's using those services. So it is an opportunity to really delve into what the coverage includes for that student. And it also, again, in some states, there's access to other places like Planned Parenthood if truly they cannot use their insurance in the way that they want to. But you're absolutely right. This is a great opportunity for students to learn about the nuances of insurance, which they will need later in life as well.
Ariel, can you maybe also comment on the telehealth PrEP and student health services?
Sure. I will say that it's an easy transition to make in that, you know, you are able to engage with somebody around the same questions that need to be asked through a telehealth format, either on the phone or through a HIPAA secure Zoom that allows you to engage with somebody where they are and still have that ability to connect with somebody around the sexual health questions that you need to ask to then prescribe them. There sometimes can be parameters of limitations in being able to get the medication to them depending on where they are in the country, but certainly if it's a refill context, it's definitely easier than starting. But also it is a question of being able to find a lab near them that they can go to get labs drawn as needed. Was there something specific, Anthony, you were thinking of?
No, I just saw one of the questions in the chat about the use of telehealth for PrEP now that we're under COVID restrictions and in the COVID era.
Yeah, I missed that one. I'm so sorry. Yeah, we switched to it immediately. We changed our protocols to support telehealth. We made sure that the providers, we investigated. So I'm in Massachusetts. We investigated what states would accept prescriptions for PrEP from us. We were at first only doing refills as opposed to starting people for the first time, and have been able to, within most states, not all of them, maintain those prescriptions as needed and help people find the care within their local state.
Awesome. So I see another question related to the work we did on Long Island, so I'll address that. So it's about how did any of the work with the college students inform what we do was the first part. And so we, you know, like I said, we have struggled for a long time to engage young people in our work, predominantly because we would meet on Thursdays at 10 o'clock at a community-based organization. So, you know, one of the silver linings that's come out of COVID has been to do things virtually, to do things after hours, to do things on weekends. We've also had some community-based partners who had some extra funding that they could allocate for some gift cards, at least to initially engage students. We've also increased our social media presence, not just with the social media platforms that the staff feel comfortable using, but also with newer things like, you know, Snapchat and TikTok and things like that, that are, you know, more young person friendly. As far as the programming and how they influence the work of the College Campus Advisory Committee, you know, we initially had asked them to attend HIV-related meetings, just one a semester. But again, the same thing happens where those meetings are really set around a working adult who has a supportive boss and environment, who could take time off work, as opposed to restructuring how the way which we do meetings to be more young person friendly through phone, Zoom, going to them instead of them coming to us. We also had given them the draft of the community presentation we made and asked them to kind of look at the words, look at the images, and kind of propose changes based on what they would want to see. And I'm happy to share all the information we've done with anyone who would like to maybe investigate doing that at their local level.
Great. Thank you, Dr. Santella. So there are additional questions related to contact information, email, phone number for the presenters if there are additional questions. There is also additional interest in the PrEP telehealth protocols.
I'm happy to share that, and I'm going to check in with Liz. This is my first time on this format. If it's easier for me to put contact information on here, or if there's going to be a way to send it out later to just the participants, what's the best way to do that?
So I think if you would like, you can add that to the participant chat box now. I can also send out information to the participants today. So if it's easier, I would just add it to the participant chat box.
Okay, I'm going to put my email in right now, folks. Feel free to email me. I have some of your email addresses, but I'm happy to share that protocol. No worries.
I will also share the email addresses from this for those who have requested the telehealth protocols with Ariel so that she can send that to you as well.
Thank you very much.
Yes.
Hi.
Are there, I know we...
May I speak?
Yes.
Yeah, I am was unable to connect through the PC, so I'm calling in, but I would definitely like to get the slides or the presentation sent to me. Can I give my email to you now so you know that it's me on the line?
If you have any questions, you can certainly email me. I think it would be best if I provide everyone my contact information. My name is Liz Lazo from the AATC NCRC. If you would like a copy of the slides, you can email me at E as in elephant, I as in ice, R as in robot, the number 8 at sn.rutgers.edu. That information is also in your registration. When you first register, that contact information, you can email me if you would like a copy of the slides. The slides and the recording will also be available on the AIDSETC.org website in the coming week.
Okay. Okay, thank you.
I know we have 1 minute left, but there was one additional question added to the chat box. What are some challenges you face when doing outreach to campuses? If you want to answer this last question.
Sure, we can do this and then close for today. So outreach has been difficult for the students to initiate because they're now going from student to student. And so student groups and professors and academic clubs, et cetera, sometimes they're looking for opportunities and sometimes they're overwhelmed with activity, with requests. And then, of course, the scheduling of it when students have different, schedules. And so one challenge was just getting the students to actually connect with their peers and faculty who weren't their own faculty and student clubs to arrange these sessions. And then it was how do you give our what we call ambassadors, the campus community ambassadors, the tools they need to do community health education. It's not, just because you're studying in college doesn't mean you have those kinds of skill sets. So we tried to incorporate that through role-playing exercises, watching other people do it in order to better prepare them, because some of these students were pretty shy. And so to put them in like a student center and say, well, we want you to do some outreach and some distribution of flyers, that wasn't everyone's cup of tea. And so that's hard. It's hard to have that kind of requirement and deliverable when everyone's not comfortable doing it. So one of the things we will build in the future is kind of some virtual, some pre-recorded modules around some important kind of cross-cutting skills like community engagement and delivering of community presentations. And on that note, I just want to say thank you again to everyone. It was wonderful having everyone here, and talk to you soon.
Thank you. We'd like to thank the speakers and today's participants. You will receive an email with the evaluation. We ask that you complete within the next week. And if you have any questions, please feel free to contact me through my email. Thank you, and have